Hi, it's Dr. Artie Kavanaugh coming to you from ACR Convergence 2024 in Washington, D.C. for Room Now. A lot of interesting abstracts. Now, I'm looking at things in psoriatic arthritis or related to, and I'm going to start out with a couple things that are related to. There was a nice seminar on uveitis, and of course, uveitis is important across a number of rheumatic diseases, but I think it's especially relevant in psoriatic arthritis. We see patients who have uveitis, and that can influence the treatment decisions. There's a seminar, Jim Rosenbaum gave a nice presentation, and there's a Dr. Lerner gave a presentation on a pediatric aspect of uveitis, which was similar although distinct. Anyway, there's a lot of data now in uveitis, and it's very exciting that it looks like we do have some options. TNF inhibitors are a natural, but there are other mechanisms that have had some interesting data that will help us manage patients for whom this is really an important comorbidity. So when we talk about psoriatic arthritis, and that was the seminar, let's look at some of the abstracts. We talk about psoriatic arthritis. We always talk also about skin psoriasis. And I think an abstract that was very interesting was 303, was an oral TNF inhibitor. This is a Janssen drug, and I think the whole concept is very exciting. The TNF inhibitors have been with us since the late 90s, and we've been using them in psoriatic arthritis since the early thousands for sure, and they really have established a central role in the treatment of psoriatic arthritis. Unlike our colleagues in skin psoriasis, where they now have better results with other mechanisms such as IL-23 and IL-17, in the joints for psoriatic arthritis, TNF inhibitors still have a central place and the most experience. We've always assumed they would be parenteral, but this is a 52-week follow-up long-term extension study, dose-finding study of an oral version of TNF inhibitor. Is it going to be just a pill with all the same attributes as the TNF inhibitor? Will there be differences? We have to see, but it's very exciting. And then one more abstract, a couple of hot topics, and that's abstract 223. Hot topics meaning the use of ultrasound, and also difficult to treat psoriatic arthritis. So this was from Ottawa, where they took patients and divided them using the EULAR assessment for difficult to treat RA, so not exactly the same, but I think it works well in psoriatic arthritis. And they looked at the patients who had difficult to treat psoriatic arthritis compared to those whose psoriatic arthritis was not difficult to treat. Interestingly, they did not find many clinical differences in the readouts that we might think would be different, such as number of swollen joints. The ultrasound also was not different between the groups. So I think this really highlights the fact that there are other factors that go on as we're thinking about patient assessments, which are of course very important to our overall treatment approach to patients. And difficult to treat is complex. It's a complex construct which includes a number of different facets, not all of which are amenable to easy analysis like with the ultrasound. So a lot of great presentations so far. We're just starting ACR Convergence. This is Artie Kavanaugh for Room Now.